Right, welcome to everybody to the Falls lecture series here at Sir Charles Gardner, and particularly to those on VC and in the room here, of course. The aim of the lectures is to increase and broaden our knowledge of current evidence and events, and process relating to falls and any of the practice changes that need to occur. The sessions are aimed at the multidisciplinary team. There's tea and coffee for you provided. My name is Anne Matthews. I'll be facilitating today's session. And it gives me, and we've also got evaluation forms for those in the room, please. We'd greatly appreciate if you could do that so that Sue can evaluate the continuation and the format for the Falls lecture series. It gives me great pleasure to introduce Chris Toy, who's an associate professor at Curtin University in older adults. And Chris also works with us here in the Centre for Nursing Research 2 days a week and very actively involved in Falls research. And it also gives me great pleasure to introduce one of my colleagues, Andrew Hill, clinical nurse consultant from aged care or care of the elderly. And they're going to do our presentation today on Delirium and Falls pilot study. Thank you very much.
Well, hello everyone, and thank you for either phoning in or coming to the talk. I'm sorry we had to delay this talk. It was meant to go ahead some time ago, but unfortunately I had a fall, so I couldn't do it. So that was a bit ironic at the time, but it served to show me just how much impact a fall does have, and it's certainly the issue of falls in hospital, as you know, is a really major concern, and particularly the risk of delirium causing a fall is what we're talking about today. So moving along. Our team was an interprofessional team. What happened actually was Sue Kitchen, who I'm sure you're familiar with. She's the Falls Management Clinical Practice Improvement Coordinator here at Sir Charles Gardner. She came to me one day and said she was really worried about the issue that she couldn't seem to bring the falls rates down in patients who were confused. She was having a lot of success in patients who weren't confused, and lots of good figures were coming through from that group, but falls, and injurious falls in particular, with the group of patients who were confused, was a real problem. So we thought we'd take an initial look at this and see if we could work towards doing a bigger study. So this is only talking about a pilot study today. It's just preliminary work. It's not going to answer all your questions, but it's raised quite a few questions for us, and it's prepared us to move forward for further work. Anne's already introduced me, and Sue Kitchen I've spoken about. Andrew Hill was involved in the research as well, and you'll see him in a minute. Dr. Sean Ma, the consultant geriatrician in the Department of Rehabilitation and Aged Care here at Sir Charles Gardner Hospital, was also involved, and Deb Edwards, the occupational therapist who works in the ED, or one of the occupational therapists who works in the ED. This is a project that was, I won't say it was run on an oily rag, it was on the smell of an oily rag, but it wasn't a funded project. It was supported by the hospital, so I do appreciate the fact that they supported it. It wasn't in monetary terms, it was in time. And when I say it wasn't on the smell of an oily rag, it was really on the passion of the clinicians who were involved. People were so keen to be involved and so passionate about this area that it was wonderful. So I want to acknowledge in particular G61 staff who were involved, and that's now G74, so just to confuse the issue even more, confuse all of us. I want to thank the people who took part in what we're calling a delirium audit. The names of the people are there, and Andrew will be explaining about the delirium audit during the talk. And I also want to thank Michelle Sin, the research assistant in the Centre for Nursing Research, who analysed the data for us and has helped with reporting. And again, Sir Charles Gardner Hospital for supporting us. So I'm sure I'm speaking to the converted here, but just to recap the background. So delirium involves a rapid onset of inattention, altered consciousness and cognition, and the symptoms fluctuate. And I think you would all know that it's, you might have this picture in your mind of what a person who's experiencing delirium might look like, and whenever anyone says to me the word delirium, the image that comes to my mind is of somebody throwing a geranium at me. When I worked on night shift in a hospital in the UK, there was a gentleman who was in for a heart condition and developed delirium. He was about 90. He climbed out of bed, grabbed a pot with a geranium in it and threw it at me and broke the window behind me. So that's what comes to my mind when I think of delirium. Of course, that's quite inappropriate, because delirium can also be a hypoactive state. It's not always as noticeable as that, and I think probably the hypoactive version is the type that's missed more often. And we also know that delirium in older hospital patients is really common, and it has really negative outcomes, including falls and falls-related injuries. And I might just mention some statistics that came from a document that's a consultation paper provided by the Australian Commission on Safety and Quality in Healthcare. And their figures here say, with regard to delirium, that can be prevented in 30 to 40% of cases and should be treated promptly and appropriately. Also, the prevalence of delirium in medical, surgical, hospitalised patients with pre-existing dementia, and we know that dementia is a risk factor for delirium, is greater than 50%. Delirium may alter the clinical course and trajectory of cognitive decline and is associated with poorer long-term outcomes. And up to 44% of patients will have unresolved delirium at the time of discharge, and up to 50% of patients with delirium in hospitals will die. So, and some of that mortality would have to relate to falls, I would say. So it's a really, really critical issue. So there's a lot of literature saying that delirium is under-recognised, and there's also literature that says that this under-recognition is associated to education deficits across disciplines. And certainly when I remember back to my nursing education, and my background is as a nurse, I don't remember much about being taught about delirium. I don't know what the situation is now. I don't teach in the undergraduate program, but I suspect there may be limited time given to it. So we wanted to know, could delirium education reduce falls in older patients? And as I say, we knew that we'd have to have a really big study to address that properly, but we wanted to do some pilot work to try and make a start on deciding whether we could move forward with that bigger study. But the thoughts behind that study, and I'm sorry this is probably rather small font, is that improving delirium education for hospital staff, including the relationship between delirium and falls, would then increase staff knowledge of delirium detection and its relevance to falls prevention, meaning that you get improved detection and documentation of delirium. So you'd facilitate treatment of the underlying causes via the documentation, so you'll be communicating with somebody who could help to address the underlying cause, such as an infection, and improved implementation of delirium-related falls risk management protocols, and that would lead to reduced falls and falls-related injuries. So that's the thinking behind what we were doing. And of course there are already lots of guidelines about what you should do if somebody is confused, and to try and reduce their risk of falling. And we particularly use the falls risk management tool. I assume that that's statewide, but I'm not quite sure about that. So the aims of our study were to provide indications, so some indications of the education's impact, and Andrew will tell you about the education, on staff knowledge and staff practice, and then on falls as the practice outcome. To determine the education's feasibility and appropriateness, and determine the feasibility and appropriateness of the study tools and protocols, so the questionnaires we were using, what we were doing. And Andrew's now going to talk to you about what we did.
Thanks, Chris. Okay, so back in 2013, in March, we commenced this process. And as you can see there, over a 3 month period is where we did our pre and post test with some education in the middle. So initially we did some pre-education data collection, and so what we looked at was all elderly patients on Ward G61, which was the general medical ward. We excluded those patients who were unable to speak, unconscious, or who came from a non-English speaking background. And so at that time we audited the patients, reviewed both their medical notes and nursing notes, and also their bedside notes as well, looking at their cognitive status, so whether we'd had some documentation around whether they were confused, whether there was actual diagnosis of delirium. Looked through to see whether there was the falls risk management tool had been completed, whether there were appropriate interventions in place. And around that as well, we looked at whether they'd had their glasses on, so they had sensory aids to help them, as that's identified as a risk factor. There were issues around whether the patient had bed rails up or down, and whether there was a reason for that. Was there any evidence that there were orientation strategies? All the rooms had large-faced clocks. The majority of them had calendars and things, thanks to our OT colleagues. But just in the notes, whether there was any evidence that the staff had made efforts to reorientate the person, had there been a review on a shift-by-shift basis if anything had changed. The tool that we use at Charlie's, just as within our falls risk management tool, just to determine a person's cognitive state, is the abbreviated mental test score. So I would assume that most of us here at Charlie's have seen that. I can't speak to the other places, but it's a 10-point tool. So you're asking the person their age, the time, the year, where they are. We ask them to identify a couple of photos of sort of a nurse and a garden, just so that they can identify those things. We want to know if they know their date of birth, some historical stuff, some memory things around the end of the Second World War, things around current activity, current things, the name of the Prime Minister or the Queen. We get them to do a count backwards from 20 to 1. So, as we know, with delirium, there's that inability to maintain attention. So that's counting backwards from 20 to 1 is a test of that. And we also, at the beginning of the test, give them an address to remember, and then at the end of the test we ask them that again to see what their memory is like. And using a tool like this is important because when we're screening people for delirium, and in this pilot we use the confusion assessment method, a tool developed by Anui and others to diagnose delirium. And so when you do that, you need to use, during a patient interview, you actually use a validated tool to identify whether the person is attentive, those sort of things. So we did this data collection pre our education session. Then in April, we implemented an education package. There were 2 education packages done, one that we combined nurses and allied health, and a second one that was run by MR for medical staff. And that was based on a case study of a gentleman who'd been on one of the wards here, had just a terrible time of it, come in for a fall at home, and through a variety of falls, head injuries, large sort of lacerations on his head, pulling out catheters, hematuria, urinary tract infections, continued to decline through his stay, and from being a gentleman who lived at home reasonably independently, ended up going into care at the end of his stay in hospital. So that was the basis for the education, and around that then we discussed the etiology, what we can put in place to prevent and manage it. And as Chris had mentioned earlier, there is a 30 to 40% of patients that we can prevent delirium in, so we stress both that and sort of ward management. So that was a PowerPoint presentation, so did that for over 30 minutes, and then at the end of it there was the opportunity for sort of questions and feedback to the participants. So in general, we looked at so at the end of the education package, we then went back and looked at collecting the data again. So again, we looked at people's cognitive status, their falls risk, or documentation again. So the same information that we collected in the pre-test. And then in May, we then had some focus groups. I need to mention that at Charlie's in April we have No Falls, what we've termed No Falls Day. So we've got hospital-wide sort of a big focus on falls prevention. The wards getting engaged about it, and the important thing with that is that there's executive buy-in to that, and the hospital believes that that's an important thing to do to address falls risk. And the literature suggests that if you want to have culture change, that you need to get that executive buy-in. So on the back of the No Falls Day, we hitched our delirium cart. Okay, so as I mentioned, we had an interprofessional package. So I did the sessions for nurses and allied health with some assistance of some other team members. I'm not sure Mark did the medical ones. It addressed the risk factors for delirium and identified the importance of detection and documentation, and also how if you link into reducing delirium, then you're going to help reduce people's falls risk. So I talked around a lot of the statistics around the much greater risk to patients who are cognitively impaired when they come into hospital, and the bad outcomes they have when they fall, which I think is probably the thing that was driving Sue Kitchen initially to sort of do something about this. We used Green's PROCEED model, so that's what we used to underpin all of our work. And so this model talks about predisposing practice change using information. And so we used education as our information, and I'll talk a little more about that. You then enable change with protocols and resources, and then you reinforce the change that you're hoping to make. So with our predisposition, we'd put our education package in place that was face-to-face. We stressed the integrated roles of the healthcare professional groups. So while we used the allied health and nursing together. As I mentioned earlier, 30-minute session, PowerPoint with associated discussion. We fitted it in around the ward, so where there was sort of regular education sessions, we slotted into those, and we continued with our education until we managed to get all the staff on the ward through those sessions. All right, so this is one of the G61 staff who we got to do a poster for us because we couldn't use there's that famous Uncle Sam poster about "We Want You." We couldn't use that for some reason. I don't know whether it was copyrighted, or there was some reason why. So one of the nurses was happy to be the face of delirium for G61. And as we go through the session, through the feedback, this was actually probably one of the posters that most of them that they remembered. Right, and so Chris did mention earlier about it in the acknowledgements about the staff on 61, and we didn't have to drag them kicking and screaming to this. It's a real issue for them. They wanted to make a difference. So there was that passion, that commitment to be involved in this session. It was extra work for them, but they willingly took that on board to make a difference to the patients on their ward. All right, so what data did we collect? So before and after the education, we surveyed the staff's knowledge using the modified knowledge of delirium survey, and that was developed by Malcolm Hare and his colleagues down in Freo. It's a 40-question multi-choice questionnaire. We added 4 extra questions at the end that just looked at people's knowledge between the relationship between falls and delirium and what actions that they should take to reduce falls in patients who are at risk of delirium. So we did that, and just to talk a little bit about the data in a minute. We then did a practice audit, and so the auditors went through patients' notes, looking at what documentation there was, whether people had documented that they had delirium or whether they just documented that they had confusion. Part of that audit process, as I mentioned earlier, was using the confusion assessment method, and so what we engaged with the patients, interviewed them, used the AMT as our cognitive assessment for that. And the confusion assessment method, to have a positive score on the confusion assessment method, and therefore we'd be pretty sure you had delirium, you needed to have evidence of the presence of acute onset of your confusion and a fluctuating course. You needed to have an inattention with that as well, and then one or both of the following, so disorganised thinking and or an altered level of consciousness. So before we used the tool, we had some education through Dr. Ma, just to make sure that we were all working from the same song sheet, and then went off and audited patients. We did that over 3 time periods over the day, because as we know, that delirium fluctuates, so we saw the patients in the early morning, the mid-afternoon, and then sort of late evening, just to make sure that we weren't missing anything if the patient's condition fluctuated. And I think that's probably it for the moment.
You'll see us moving across a few times today. So I'm going to talk to you about the findings now. And first of all, I'm going to talk to you about the impact on knowledge. So if you remember, we looked at impacts on knowledge, on practice, and then practice outcomes being falls. So the questionnaire that we used, it provides several domains. One looks at the definition of delirium. One looks at the tools used to identify delirium. Another looks at risk factors. Another looks at the ways in which delirium may present, so symptoms. And then the questions that we added, and Andrew's already told you about, looked at the link between delirium and falls. So we'll go through those findings first. What's interesting though is that the way we did this was we surveyed all the staff before the education. We did that by sending the survey forms to them and asking them to return them into a box on the ward. And we gave the education, and then they answered the questions while they were still in the room after the education. We didn't do any follow-up, and that's a limitation of our study. But it also meant that we got a much better return rate immediately after the education. There was an argument, and we had a lot of debate about this. I think you remember, Andrew, that we talked a lot about whether we could give the questionnaire immediately before the education session, then the education, and then the questionnaire at the end. But the time limitation was too great to do that. So these are the participants. So you can see we had 28 people provided responses before the education and 50 afterwards. So that was really the result of us administering the survey in that way. And the pale blue bars at the bottom are the before time numbers, and the dark blue ones are the after. So we had new grads, they were new nursing grads, we had other nurses, allied health professionals and doctors. there weren't a great number of doctors, but we were lucky to get any. I think we were, and it's always a challenge to recruit medical staff, and it was because Sean was on board with that, but we were able to do that, so it's great. So when they responded to, it's really one question about the definition of delirium, so I gave several options of the definition of delirium. There were only 2 incorrect responses at each time point, which is really encouraging, so that's what we want to see. Basically, people knew what delirium was. Then we looked at tools used to identify delirium, and Andrew has already spoken about the CAM, the Confusion Assessment Method, which is, I think, basically the gold standard tool. That didn't differ beforehand. There were 39% got that right, that question right, and only 40% at time 2. So obviously we didn't address that sufficiently well in our education. So that is an indication for changing our education. And it's quite disappointing that generally people didn't have much knowledge of the CAM. We did make a slight difference, more than 10% in knowledge of the MMSE, the mini mental state at scale, and the delirium rating scale, which surprised me, that delirium rating scale, because I thought kind of a given. Now let's look at the risk factor questions. So there was an improvement across the board in knowledge of risk factors of delirium, particularly in the allied health staff. They were the stars there. They jumped quite considerably. But overall, we were really happy with that, and that was a significant improvement. So we, when we looked at a significant change, we looked at it for the 22 people who completed at both time points. So we did paired analyses. So it's only a subset, but for those that are interested, P was 0.001, so it was really highly significant, the change in knowledge in that group who did the questionnaire at both time points. Presentation questions, so that's about how you recognise delirium. So that there were 14 items, and the first time we asked the questions, the range of responses went from 0 to 11, and then it went from 4 to 14. And again, there was a highly significant improvement for the 22 people. And look at allied health, they're spot on here. So that's really good. And the questions we had about delirium and falls. Don't know what happened to the doctors there. Allied health again was stars, and there was another highly significant improvement for the 22 people who completed at both time points. So knowledge definitely changed, which is good. Not surprising, but it's good. So the impact on practice, this is the audit that Andrew was talking about. I think he's coming back now to talk about it again.
Okay, so just to reiterate what we were looking at again, so within the practice audit we were trying to identify how much delirium was detected versus confusion or delirium documented. So often people will write that the patient appears confused or pleasantly confused or with such effect in the notes, but often there's never any sort of delineation of whether they think they're delirious or whether they have dementia or some other issue. We were looking at whether the falls risk management strategies improved, were people more aware of the risks to their patients if they had delirium or some other cognitive impairment, and whether there was an improvement in the number of falls from pre the education and post the education. All right, so all the patients that were found to have delirium, so 5 out of the 23 that we assessed, were also documented as having delirium or being confused, so prior to our audit. So people were identifying that there was some confusion or some delirium in that patient group. So the literature often suggests that people just come into hospital and nobody identifies any sort of sort of delirium or confusion, and so it was good to see that people were sort of identifying it. Then after the education, again, 70% patients were also documented as having delirium or being confused within 24 hours prior to the final audit. So the improvements that we found, that the completion of the AMT forms was much better. And again, there's sort of variable knowledge around the place about the use of the AMTs. People often, because it's a piece of paper, often find it onerous to do, although really 10 questions it doesn't take that long to do. So we're finding that more of them were done. And part of the process is when people have a low score on their AMTs, that then the process is that then you refer them either on to occupational therapy for sort of further cognitive screening, as well as mentioning it to the medical team that the patient has been identified as being confused. There were improvements in the strategies around reorientation, the use of companions, and implementation of challenging behaviour charts. So people were remembering what we had talked about in sessions, but also sort of thinking a little bit outside the box, trying to identify, getting deeper into what the problem was. So things like the challenging behaviour charts, people were looking to see if there were patterns, there were things that they were doing that were making a difference. The compliance with the relevant elements of the falls risk management tool. So there were, as you can see, before the education and some after. We did believe that our observations were inconclusive. There were issues around documentation of people's, whether they wore glasses, that visuals, those sort of aids. We weren't really sure whether people wore those or not. There were issues around sort of people's, bed mobility, the use of bed rails, that sort of stuff as well. So we really just sort of, it was probably inconclusive there. Okay, so impact on falls. So this is the data for patients over 65 on G61. So again, it looks like we've had a positive impact on falls, although we couldn't make any clear link between this and practice change. And I think it just indicates that really we need to do more pilot work before we get into a large study again. So as part of the process, we ran focus groups. So we ran 3 focus groups in May. So 15 attendees from Nurses and Allied Health. No doctors attended our focus groups. And questions we asked were around the feasibility of education sessions. And what came out was that people were appreciative that there were plenty of sessions that were done over a variety of times of the day. There were issues around venues and equipment. I think that's probably the same in most places and doing a lot of education. We used the handover / tea room on the ward, and so again that was quite small. It was sort of, people were shuttling in and out and nurses were being pulled away to go and do things. So the information from the focus groups was that really venues needed to be free of distractions and interruptions. Some felt that the handover room was a little close to home, so that much as they wanted to stay and be involved, that people were still popping their heads in and grabbing them and taking them away. We did use sort of a lecture theatre for a couple of them. The staff felt that was much better because it was away from the ward. It was set up to do education. And that inconsistency about not having one set place was also raised, that really, that inconsistency staff felt wasn't good. as I said earlier, we kept going with education until we covered everybody. So that wasn't just day staff, that was night staff as well. So I came in and did sessions for the night staff to engage with them as well. And some of the sessions were, we had sort of up to 8, 10 people at some sessions, and then towards the end, it's just sessions for 1 to 2 people when we were trying to catch up with everyone. So people felt that they liked the case study approach, and particularly that it was a patient who was a medical patient, was very relevant. People had seen this, could apply this because they'd seen this before in other patients. This found it especially valuable that there was information around how to identify delirium and how delirium differs from dementia, because again that's often one of the where we trip up a little, because people will make assumptions about older people and their confusion that this is just they're old and they've got dementia and they don't bother to sort of think about it, maybe that's a delirium. And of course if we do that, then people's outcomes are much, much worse, because as we know with delirium there's an obvious cause, and the sooner that we get on and spot that cause and start to treat it, so much, the patient has such much better outcomes. There was thought to be good that there was multidisciplinary, but there were some feelings that maybe sort of there needed to be a little bit of role delineation, so what the various responsibilities were for different staff groups. So a little bit some examples of what people had thought about it. And so we did sort of at the beginning have some discussions about whether we would just have one presentation for all, but it was felt that there was probably specific needs for different groups, so that's why we went with 2. And then when we wind up at the end, we'll talk about what we think would be good for the future, and part of it around sort of how what education you provide is part of that. As part of it as well, we provided a folder on the ward, so that was just to reinforce the education that we had. And so we had a large orange lever arch folder, and we chose orange because that's the, I'll just grab it. The clinical practice guidelines are in orange, so we just thought we'd go with orange. So we had a big orange lever arch folder, and within that we'd put the nursing practice guidelines. So we have a practice guidelines for the care of the older person with delirium at Charlie's. So for those of you who work here, that's practice guideline 23. So we had a copy of that. We had a copy of these clinical practice guidelines within it, and we also had a copy of the Falls Risk Management tool. It was under-recognised and not particularly well utilised, and I have to say that towards the end of when I went to collect it, when we finished the pilot, I couldn't actually find it, so obviously it had gone somewhere. Part of us, the staff, felt that having a checklist to guide them was good, and the nursing practice guidelines, although not a checklist, is in variety of, is in dot points and under sort of the various risk factors for delirium, so it actually could just give you a cue to like what things you probably need to do. Time was identified as a barrier to accessing the folder, and particularly sort of when you're sitting down and maybe just scrolling through this, people felt that it was it's a bit much. They felt daunted by the size of it and going through it. So some of the suggestions were that maybe we should have left it in the tea room so people would browse it at their leisure. The other thing that we talked about at this was the use of a delirium sticker, and this was come out of northern Sydney, and it's just a small sticker about yay large that sits in the notes that looks at, you know, people's pre-morbid risk factors, and you work through that, give your patient a risk score, it then gives you a small list of recommendations, and then links you into a small number of protocols for just to guide your practice. The staff felt that that would be useful. That's something that we don't currently do, but the feedback was that that might be useful with a little bit of better linkage into our practice guidelines here, and, you know, with scoring between low and high, you know, some probably better direction with what to do at each of those sort of levels. So appropriateness of the posters. So we had a number of posters up. You've already seen the one of Face of Delirium. We had also some posters various sizes about how to prevent delirium, and they were deliberately sort of pretty generic, because besides sort of nurses and allied health staff, we also wanted sort of the AINs and families to sort of just see this stuff around and just engage with it. We had some algorithms about management as well. So the feeling was that generally people thought that the posters tended to lose their impact. They thought that particularly the posters that had our algorithm about you know, how to identify delirium and manage it, and it's primarily around pharmacological management. They felt that was beneficial, but as I mentioned earlier, the poster that they most remembered was the one of their colleagues. So I think probably if we could have that poster plus some really salient points, then that would be the best of both worlds. All right.
Okay, so we also asked about the feasibility and appropriateness of the data collection tools and the study protocols. There were mixed feelings. I've already talked about when administering the questionnaire, the knowledge questionnaire would have been appropriate. There were mixed feelings on that. But obviously there were comments that it would be good to know whether knowledge was sustained over a period, and we would certainly do that in a larger study. The questionnaire was actually quite popular. When I spoke to people about it, they quite enjoyed doing it, and they would have liked to be able to directly compare their before and after knowledge scores. And in fact, we used the questionnaire again in a recent Falls Day. I think it was up here, wasn't it? That Sue Kitchen ran, and people were elected to do it voluntarily, so it's good. It was quite popular. The audit was problematic from our perspective in that, as Andrew has pointed out, it was really hard to draw conclusions from some of the things we were looking at. For example, if we were looking at whether patients were wearing their glasses or not, we couldn't always determine from the documentation whether they should have had glasses. And sometimes, in actual fact, we ended up with some figures showing that more people were wearing glasses than should have worn glasses. So when you're doing an audit, you're looking at documentation, and sometimes there are problems within the documentation, maybe in different places than you think it's going to be, or missing, whatever. But from a ward point of view, the ward didn't find the audit at all disruptive, even though they had visits from teams of people 3 times a day before and after the session. Okay, and so let's move on to what conclusions we've drawn. So obviously we had a positive impact on staff knowledge. So we've got an opportunity now to look at where we didn't have a positive impact for particular items and make a difference to the education. The audit, it was difficult really, because we accepted in the medical records documentation of confusion as well as of delirium, and I don't think we should have done that. I think really we needed to stick with delirium, because making comparisons, we don't now know. We know more people were identified as being confused in the notes than were detected as having delirium, and theoretically that is quite feasible that it was delirium, because delirium fluctuates, and if you're there all the time you might pick up more cases of it. But we don't really know if it was delirium or if it was perhaps dementia that was documented as confusion. So some blurring around that, and I think that's what I'm learning throughout this process, is that people talk consistently about confusion, and it's not determined to be either delirium or dementia or a combination of the two. We're very loose in our terminology, and I think that's a problem for me as a researcher, and it's a problem probably for clinicians. I don't know what you think about that. But there were certainly some signs of improved adherence to protocols, so falls risk management protocols. But as Andrew has said, we need to look at the education with respect to roles for particular groups. So part of the interprofessional education is probably not just a case of going and having joint education sessions so that we've got a common understanding, although that's good, but we also need to know how the roles of people fit together when we're addressing a particular problem, and I don't think we did that adequately. So we need to look at that in our future work. We've talked about education, location and so forth. It was a real problem, I have to say, because I sat in a lot of the education sessions, and there were people being called out all the time, and people couldn't find the education session because it had moved. There were lots of problems around that we really have to get on top of somehow. My theory is that if we can actually show that this kind of thing makes a difference, that actually manifests in terms of the healthcare budget, we will get this rolled into ongoing education, which it really needs to be. But until we reach that point, we're probably fighting a bit of a battle. There was a query about whether we should have the doctors in with the allied health staff and the nurses. When we ran the education, there were two schools of thought on that, and so there were pros and cons, because you want everybody to have this consistent knowledge and use the consistent language, but the argument of having the doctors separately was that they might need to have a lot more technical information about particular drugs that interact and so forth. So one thought was that we might have one baseline module for all the staff and then separate ones for professional groups, but it's still under discussion. And it's been really a very useful process to inform us with regard to further work. Raised a whole lot more questions, but we're well prepared now. And I think really it's very much about implementing evidence-based practice. We know what we should be doing. We can do it. We just need to keep on top of this constant reminder and alertness to delirium, and knowing that it links with falls. So it's a doable thing. So if we have a future project, we could look at perhaps applying for some SHRAC funding, so that looks at costs of care, because if somebody falls, it's a very costly process for the healthcare system. So if we reduce falls, that would be good. And we could also look at an NHMRC partnership project, which is all about implementing evidence-based practice, which is really what this is about. And I need to acknowledge there's a lot of other work going on in this kind of area. In particular, I know that Malcolm Hare and Diane Winarden work in this space, but also there's Anne-Marie Hill. There's a whole load of other researchers working in this space. It's really, really important work. We need to make sure we're all working together and not against each other. So, that's a picture of most of the team, but I haven't got Deb Edwards' photo, so I couldn't put her up there. And references, and I'm happy to be contacted. Feel free to ask questions now, but I'm happy to be contacted as well with any questions. And I've got a lot of the stuff that we included in the folder and the questionnaires. If anyone wants to look at what we had, I'm happy to do that. So, any questions? I'm very quiet. Comments? They're all disappearing on the screen. Okay. We've probably filled up our time anyway. So. All right. Thank you very much for coming.
Thank you very much.